You are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Open. Yes, we are still in the era of anatomy of clinical importance. And my friends, this is today's case study. A 53-year-old woman recently experienced changes in her menstrual cycle, said that during some of the months the flow was not consistent with what she previously experiences, and of course some of the months too she does not experience the menstrual flow. Now, apart from experiencing the changes in the menstrual cycle, this woman also experienced hot flashes coupled with night sweating, of course dyspareunia, vaginal dryness, mood swing, and importantly insomnia, especially at night. Now, she indicated actually to her primary healthcare provider that the situation over the past weeks or so had become worse, and therefore sought some kind of advice and management from her primary healthcare provider. So this is the question or the case study before us. Now, the first thing is that we want to understand that based on the signs and symptoms that this patient is presenting, what is your most likely diagnosis? So our answer may be either perimenopause or menopause, for the reason that now this patient is supposed to experience no menstrual flow by way of the menses for at least 12 months before we can clearly say that she's in her menopause. Otherwise, based on these symptoms talking about irregular menstrual cycle, then we can say that she is in her perimenopause, which of course the signs and symptoms that of course this patient is experiencing, of course is going to be the same. Now, if we are able to get, based on what this patient or this client told, her provider, by way of the situation getting worse in the past few weeks or so, then we can relate it that it has been for more than, let's say, 12 months, and that's why it has become worse. And so she's now experiencing the real menopause conditions, so to speak. But understand something, that menopause is not a disease. That's the most important thing that I want you to become aware. Now, the first question, of course, we've seen the first question, by way of diagnosis. The second question is that what are the main signs and symptoms indicated in the question that suggests to us that this patient is in that kind of condition? Yes, we've said it. There could be that kind of hot flashes. We've mentioned night sweat. We mentioned dyspareunia. And whenever we talk about dyspareunia, we are talking about pain experienced during sexual intercourse. That is dyspareunia by the female. Experiencing that pain during sexual intercourse. And the main thing is that there is vaginal dryness, because of course there's going to be something we call atrophy of what we call the vaginal wall. These are the things that we'll be seeing. No doubt about that. There will be mood swings. There's that potential for depression. And one thing too is that this individual may experience urinating, especially often at night, and that is why she may also experience insomnia, that is difficulty in sleeping. So these things suggest to us that this patient is in her perimenopause, or in the menopause proper. Now the third question is that what is the name of the hormone that's the culprit in most of the signs and symptoms that this patient, yes, is experiencing? My friends, your answer that I want you to give is estradiol, and that is E2. Because one thing is that female estrogens, we have a lot of them. We have E1 all the way to E4, but the functional estrogen that is responsible for maintaining homeostasis in some of these things is, my friends, estradiol. Okay, so that once you are in your menopause, the level of estradiol, yes, goes down drastically. So that's the important thing which I want you to become aware of. Now the fourth question is that what is the basis for, of course, decline in, of course, the estradiol, okay, during menopause. Now the basis is simple. Females, God, okay, gave females a predetermined number of ovarian follicular, ovarian follicles actually. And these follicles, they are in the primordial stage. So what happens is that, to cut the long story short, at birth, a female presents with about 1 million. Yeah, some people may have 800,000, some people may have 1.2 million. But on average, 1 million follicles, okay, are given to females in their primordial stage. Saying that every month, now what we see is that by the time the female gets to menopause, what we see is that you have about 600,000 getting destroyed, dying at various stages of development, whatever, through a process that we call atresia. Yes, so most of them will die and they may not be able to develop. Now, during puberty, a cohort of them every month by each ovary, okay, except of course in some situations where both ovaries may select a cohort of them for development. Now, during that developmental stage, let's say about 20 of them are selected for a particular month, okay, eventually what we see is that they go through the development under the influence of follicle stimulating hormone. We see that their follicular cells will be transformed to become granulosa cells. And of course, the immediately surrounding stroma will be converted to what we call thicker interna, thicker, and eventually differentiating thicker interna, of course, thicker externa. The thicker interna, yes, together with, of course, the granulosa cells, will help in manufacturing of what we call the estradiol. Very important. And so during the pre-ovulatory phase, before ovulation, we see a lot of the estrogens, especially estradiol, produced. But of course, the granulosa cells, okay, of the follicles, together with, of course, that of the thicker internal cells, they work in synergy to produce the estradiol. So that, of course, at the end of the, by middle of the menstrual cycle, what happens is that only one of them will emerge as the Griffin or the mature follicle to be ovulated. That is what we see. So it means that once we're able to go through the menstrual cycle every month, what we see is that once a cohort of the follicles go through the development, then it tells us that under the influence of FSH, then the granulosa cells of the follicles together with the thicker internal cells will help to make estradiol. But what we see is that getting to perimenopause, what we see is that the number of follicles reduce drastically. Let's say we have 1,500 or whatever, and for that reason they are not able to respond effectively to the FSH, and that is when the perimenopausal signs and symptoms begin to come. Okay, so it's a gradual process. So we go through the gradual perimenopausal symptoms, okay, and that one, some of them may produce some small estradiol, and that is why we see experiencing those symptoms in the perimenopausal stage. It will get to a time where essentially, virtually, all the follicles, okay, will get diminished, and that is when you reach the menopausal stage proper. Okay, that is one thing I want you to understand. Now the next question is that why is this patient experiencing most of these signs and symptoms together? And I want you to know that together with some complications like osteoporosis. Okay, and so your answer is that the main thing, it has to do with decline of the estradiol. Say that if your estradiol is so low or it get depleted entirely, then of course regulation on the hypothalamus by of the estradiol to help with of course temperature control, yes, will also be impaired. And that is why the patient will experience of course the hot flashes together with of course the night sweats. And one other thing too is that yes, estradiol also has influence on serotonin, where it's also very important, of course, managing your mood and all that. That's why the mood swing and all that, all those depression mood also gets into the picture. Okay, and of course, it makes sense that it has also influence on, of course, the vaginal epithelium, saying that the mucosa of the vagina, yes, by way of its epithelium, yes, it will become, it will decrease, drastically, and that is when we're able to see the vaginal dryness, so that during sexual intercourse, there is painful sexual intercourse. Okay, yes, no doubt about that. That estradiol also plays an important role as far as yes, bone deposition is concerned. Now, always I say that bone deposition and bone resorption, and that's bone breakdown. Yes, both of them take place as you are there, but one becomes greater excessively by way of the bone resorption, especially postmenopausally. So once you are in menopause and estradiol is not having the anabolic control, say that we don't deposit more of the bone, but rather, we see more of osteoclast activity, breaking down your bone. Then of course we see a lot of the porous in there, and then it can, easily get your bone fractured. So these are the things that I want you to become aware of. Now, the next thing is that, what are the things which will precipitate, by way of the hot flashes and of course the night sweating? And the important thing is that when you take in spicy food, you have that issue, especially spicy food. Okay, oily food, spicy food, importantly, it becomes a stimulus, okay, to make the night sweating of course the hot flashes even worse. Yes, and that is why the individual should wear light clothing, okay, and of course get to a place where the aeration and of course the conditioning of the air is proper. Okay, so my friend, this is a short meeting trying to help you understand some bits of the concept of menopause. So in future sections we'll bring in some of these things so that we can appreciate whatever we learn in the clinical setting. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.